Good afternoon, everyone. Welcome to today's DCRI Research Conference. So for many of you, you may know that actually November is Diabetes Awareness Month, and we're squeezing this in the end of the month. And this year's message is, be smart about your heart. And we couldn't have asked for a better speaker to help us understand the relationships between diabetes and cardiovascular disease and some of the exciting work that DCRI is a part of. Dr. Green completed her undergraduate and medical degrees at the University of Virginia prior to coming to UNC, where she finished her internal medicine residency in 1996, followed by a fellowship in endocrinology here at Duke, finishing in 1998. And she's been here since, rising through the ranks, is now an associate professor of medicine. She's been chief of endocrinology, metabolism, and nutrition at the VA since 2002. And has been very active at the DCRI, involved in a number of very exciting trials. Her personal research interests are on focusing upon strategies to predict, prevent, and treat diabetes mellitus, but also various interventions that help modify glycemic control, dyslipidemia, and hypertension. Particular trials that she's been involved in include ACCORD, Bari-2D, and the recently initiated GRADE study. She's also had a number of key roles in trial development, operations, and all sorts of other ancillary aspects of trials, including event adjudication for several major trials, including TCOS and EXCEL. So please join me in welcoming Dr. Green for presenting today.
Thank you very much. Can you hear me in the back? Great. Okay. Don't forget to text to the number on the screen if you'd like to get CME credit, but it won't be active for a little while still. Thank you very much for the invitation to speak during National Diabetes Month. And the topic that I was asked to speak on is addressing the global burden of diabetes and whether or not promising new therapies will be sufficient to address this. And this is rather a large topic. So I'd like to preface this just with to let you know that this is going to be a relatively high-level look at this issue and probably heavily skewed towards what I find interesting, but hopefully this will prompt a lot of discussion at the end of the presentation. These are my disclosures. And today what we're going to talk about, you've probably heard this a number of times, but just to review the current and projected prevalence of diabetes in the United States and worldwide, talk a bit about what we know with respect to effective or promising strategies for diabetes prevention. We're going to talk about options to reduce diabetes-related complications, and then we'll, at the end, talk a bit about whether or not the current clinical trials landscape in the diabetes area appears to be well positioned to answer the kinds of questions that we'll need to have answered to address this problem. So this slide only goes up through 2010, and I'll have some more up-to-date information on the following slide, but it really is intended to give us sort of a feel for the increasing number and percentage of individuals with diabetes in the United States over time. And you can see that particularly around 94, 95, there's been a pretty steep and steady increase, and not really a sign of leveling off just yet. And it's important to note that adults in the United States are not sort of necessarily universally affected by diabetes, but that the percentage of those diagnosed with diabetes really goes up pretty dramatically amongst those age 65 and older, men being a little bit more likely to be affected than women, or at least diagnosed than women. And of course, there's quite a bit of variability with respect to the percentage of individuals in certain ethnic groups who have diabetes, and in particular, Native Americans, African Americans, and those of Hispanic descent being predominantly affected or more significantly affected than those of other ethnic backgrounds. And that's certainly relevant to the design and enrollment of clinical trials moving forwards. So you probably know this as well, but it's really interesting to look at in a graphic format that really rates of diabetes tend to follow rates of obesity. And what this shows, it may be a little bit difficult to see in the back, is that over time, this is the trend between 1994 and 2010, you can see that the heat map of the United States, which is becoming sort of more orange and red over time, shows an increased prevalence of obesity over time, and then it usually takes a number of years for the diabetes diagnoses to catch up, but usually the same states, the same parts of the United States are affected by diabetes, and it really mirrors the prevalence of obesity in the same areas. And you can see that North Carolina and many of the southeastern states are primarily affected and are referred to as the diabetes belt. But of course, it's not just the United States that's affected, and this is intended to give really sort of a snapshot look at the worldwide scope of the problem. And the United States, you may not be able to see, North America certainly has the highest prevalence of diabetes. It's at about 11.4%, but the remainder of the world is certainly not spared. If you look at, for example, the Western Pacific, even though the prevalence is lower at, I believe, about 8.5%, really enormous numbers of individuals living with diabetes. And the other interesting thing to note from this slide is the percentage of individuals in these various regions who have diabetes but had not yet been diagnosed with the condition. So for example, in Africa, not as many people living with diabetes, but a very significant percentage, 62.5%, not yet diagnosed. So different issues related to diabetes appear to affect different parts of the world. And then, of course, in the future, I've not heard yet that the prevalence of diabetes is expected to plateau or decrease at any point. And in fact, by the year 2035, there should be over 200 million more individuals affected worldwide. I think the most recent data in the United States that I've seen suggests that 1 in 3 individuals in the United States will have diabetes in the year 2050, so if current trends continue. So diabetes is, of course, expensive. These are just US costs. The total cost estimated in 2012 associated with diabetes, diabetes care, care of diabetes complications, as well as indirect costs such as disability, work loss, premature death, totaling $245 billion, so really quite significant. And diabetes is expensive not because we need to lower glucose with medications, but because of the complications that can ensue from uncontrolled hyperglycemia and the associated conditions such as hypertension and dyslipidemia associated with diabetes. And we tend to have traditionally focused more on what are called the microvascular complications, so retinopathy, nephropathy, and peripheral neuropathy or autonomic neuropathy as sort of the traditional complications of diabetes. But it's very clear that individuals with diabetes are at extremely high risk for macrovascular complications as well, such as stroke and cardiovascular disease. I believe hospitalizations for cardiovascular disease represent the majority of hospitalizations of individuals affected by diabetes, and 8 out of 10 individuals with diabetes will die from a cardiovascular complication. So given that the enormity of the problem, what do we know so far about the utility and effectiveness of preventive efforts? Well, they tend to fall into 3 or maybe 4 categories, with the primary one being emphasized is lifestyle modification. But there is some data to support approaches including medical therapy, surgical intervention, and there are probably others as well. And probably the most famous prevention trial is the Diabetes Prevention Program, which is certainly not, this isn't new data by any means, but very clearly showed that in a group of individuals at high risk for the development of type 2 diabetes, that interventions such as intensive lifestyle modification, or metformin reduced rates of diabetes, and the very intensive lifestyle modification reduced the risk of diabetes by 58% at 3 years and 34% at 10 years, whereas metformin being a bit less effective but maybe easier to implement, reducing the risk of diabetes by just over 30% at 3 years and 18% at 10 years. You tend not to hear as much about the use of the thiazolidinediones in diabetes prevention for a variety of different reasons, but people tend to forget that triglycerin was also one of the randomized treatments in this, assigned treatments in this diabetes prevention program. Now that therapy had to be discontinued very early on in the trial because that medication was associated with significant risk of hepatotoxicity. But interestingly, during the period of time that individuals were still taking that medication, the thiazolidine appeared to reduce the risk of conversion to type 2 diabetes most significantly. However, even though the newer agents in this class appear much less likely to be hepatotoxic, there are other side effects associated with that class of drugs, such as volume expansion, increased risk of congestive heart failure, fractures, et cetera, that really have limited the utility and certainly the acceptance of the use of that class of drugs in a preventative sense. There are a variety of other medicines that have shown some utility in similar populations. So agribose decreases the risk by about 25%, orlistat, a weight loss medication, by 40 to 52%. And then there's some interest in looking at other types of interventions, such as vitamin D, supplementation in high-risk groups to reduce the rate of conversion to type 2 diabetes. This is a little tough. It's a good thing that this trial is being performed. Vitamin D levels tend to be kind of a marker of good overall health. And when you check, measure vitamin D levels across a population, the people who are healthier often have, or at lower risk for disease such as diabetes, often tend to have higher or certainly normal vitamin D, whereas those who have low vitamin D levels tend in general to have more medical problems. What's not clear is whether or not actual vitamin D replenishment or therapy reduces the actual risk of those disease in a controlled clinical trial. So this is an NIDDK-funded study. There is a site here. We'll determine whether or not vitamin D supplementation with ergocalciferol 4,000 international units a day compared to placebo will reduce the risk of conversion to type 2 diabetes. So that's certainly very promising. This is certainly would be a very cost-effective intervention, but certainly remains to be seen whether or not this will be an effective approach. Perhaps most interestingly is the data from the bariatric surgery trials. Now, the difficulty in looking at this kind of information is that these are generally not data collected from randomized controlled trials, but essentially they take a group of people who are obese and at risk for type 2 diabetes, and then some of them get surgery, and then their results, their outcomes are compared to those similar patients who did not undergo bariatric surgery. So there's certainly significant limitations to our ability to determine the effectiveness of bariatric surgery in diabetes prevention, but it really, at least this data looks really quite impressive, with an estimated risk reduction of almost 80% in individuals who are obese, and even higher rates of risk reduction, so 87% risk reduction in obese patients with impaired fasting glucose. And very interestingly, some very recent data suggests that that benefit may even convey to those individuals who weren't really heavy enough to meet the guidelines for bariatric surgery in the first place. And so this may be something that could be explored in individuals moving forward who are at high risk for diabetes, but perhaps not as heavy as the group that we've traditionally considered for bariatric surgery. So, having gone through all this, what's the problem? Why are the rates of diabetes still so high and ever climbing? Well, for one thing, when we talk about lifestyle is fairly hard to implement and sustain, and it's been very difficult to reproduce the impact of the lifestyle intervention in the diabetes prevention program out in usual clinical practice. It's very resource heavy. There have been some trials demonstrating success using methods of correspondence like email or texting to participants, but that obviously isn't going to be an option for everyone, and certainly not for many of the parts of the world that are highly affected by diabetes. But there are some limited attempts to translate that in a user-friendly way into kind of real life, but it's been with limited success so far. As I've alluded, so the safety and tolerability and sort of general medical acceptance of the medications used to prevent the development of diabetes in a high-risk population is kind of variable. And at the present time, the American Diabetes Association really only recommends consideration of metformin as a preventative intervention, and only in certain groups of individuals. And that's partly because metformin doesn't really seem to work very well in everyone. It really works best in people who are younger and heavier. So individuals who have diabetes, have pre-diabetes but have a lower body weight or who are older may not benefit at all. The other thing we don't know is we don't really know yet how effective these medications are in a preventative sense if they are used in addition to lifestyle modifications. So in the diabetes prevention program, you either got the intensive lifestyle modification support or you got medication. You didn't really get both. And I think there's a general tendency to not want to discourage lifestyle modification because we know it's probably the safest and most effective intervention. These interventions, particularly bariatric surgery, it's not really available or accessible to everyone. Even in developed countries, it can be a challenge to find the money to pay for that sort of intervention or ensure that your insurance will cover that. And the other thing, and probably the most important piece here, is that it's not really clear, for example, when we give someone a medication to prevent diabetes, it's not entirely clear what we're accomplishing in a physiologic sense. And some have argued that you're essentially just starting medication earlier in the disease process. And it's not clear that the underlying pathophysiology, the natural history of the disease is altered in any way, or if there will be long-term benefits with respect to the development of complications. So there just hasn't been tremendous uptake of the use of medications in a preventative sense. I'm going to shift gears a little bit and now talk about what we know, again, in a broad sense, about what we accomplish when we treat type 2 diabetes, and to really focus first on what we know about glycemic control. What's very clear, and in particular from the UK-PDS trial, that better glycemic control in type 2 diabetes reduces the risk of those microvascular complications that I had mentioned, so retinopathy, nephropathy, neuropathy. And then, first, the good news. It does look like, also from the UK-PDS trial, that if good glycemic control is initiated early on in the disease course and sustained as best as possible, that there is probably some sort of a legacy effect or metabolic memory that over the long term will reduce the risk of cardiovascular complications much later in life. But that's not universally true, and I will explain that a bit later. But first, again, just recap what the UK-PDS trial intervention was. This was a trial, of course, in the United Kingdom that enrolled a group of individuals with either newly diagnosed or very recently diagnosed type 2 diabetes, and they randomized them to essentially an A1C target. And this was not a trial of a particular type of diabetes medication, but instead designed to assess the impact of more intensive versus less intensive glycemic control, because frankly, at the time that this trial was started, it wasn't clear that managing hyperglycemia well had any benefits other than alleviation of hyperglycemic symptoms. So essentially what you can see over time is that compared to the conventional group, the intensive group on average had an A1C that was about 1% lower than the more conventionally treated group. Now, the other thing to notice is, of course, this sort of Nike swoosh of A1C that we tend to see in lots of trials of diabetes management, where there's an initial improvement in glycemic control, but then a deterioration over time. Now, fortunately for us, when the active treatment portion of the trial concluded, they continued to follow these patients for a number of years afterwards. And what this slide shows you is that essentially in that follow-up period where patients were returned to the care of their usual diabetes care providers, the two groups had essentially comparable overall glycemic control. So remember, the initial study period, the two groups were assigned to more intensive versus less intensive glycemic control, and then for the subsequent years essentially just followed, and the glycemic control essentially equalized in the two groups. And if we just look at the initial trials data from 1997, what you can see is that at the end of the active treatment period, it was very clear that better glycemic control reduced what was described as any diabetes-related endpoint, but more specifically, dramatically reduced rates of microvascular complications. At the time, there was a trend towards a reduction in rates of myocardial infarction that did not reach statistical significance, with the exception of a small group of individuals who were heavier who had been randomized preferentially to metformin therapy. But overall, tighter glycemic control did not appear to reduce the risk of myocardial infarction or all-cause mortality. Now again, fortunately, they had continued to follow these people afterwards, and when they looked again at these groups of individuals 10 years later, they found that those who had been treated more intensively earlier on still had significantly lower rates of microvascular complications, but now also had significantly fewer myocardial infarctions and were less likely to have died from any cause. So thus, the explanation and the really reason that we try to establish good glycemic control in individuals early on after diagnosis, because it does appear to convey both a short-term benefit with respect to microvascular complications, but a long-term benefit which includes macrovascular complications as well. Now, remember that these were all people who had just been diagnosed with type 2 diabetes, and not every patient that you see is like that, and not every patient has had good control since the time of diagnosis. In fact, most don't. And when the initial results of the UKPDS trial came out that did not demonstrate a cardiovascular benefit, people thought, we were trying to explain that, and some of the theories were that, well, maybe they just didn't do this test in a sick enough population to see a significant difference with respect to cardiovascular complications. Or maybe they just didn't try to get the A1C down low enough in the intensively treated group. Maybe it would be good for patients if we try to get their A1C down into the normal range. And so you could talk another hour about the trials that ensued to try to answer those questions. What I'm showing here is some information from a meta-analysis in The Lancet in 2009, which included the UKPDS data, as well as trials that were designed to assess the efficacy and safety of very intensive glycemic control in much higher risk populations of individuals, the ADVANCE, VADT, and ACCORD trials. And these trials certainly weren't exactly the same, but they clearly enrolled individuals who had diabetes for significantly longer periods of time, were much more likely to have established complications, including cardiovascular complications. And you can see they got the A1C down pretty low in the intensively treated groups, particularly in ACCORD. Now, PROACTIVE is here. This really wasn't a trial designed to assess the impact of different intensities of glycemic control, but at the end of the day, that's essentially what happened. So that data tends to be included in meta-analyses of these type anyway. So if you really look at the data from all of these trials, which were large long-term trials, really specifically designed to assess cardiovascular rates of cardiovascular complications, you can see that tighter glycemic control does seem to be associated with a reduced risk of non-fatal myocardial infarction and what has been described as coronary heart disease events. So that intends to include things like cardiovascular procedures as well. However, there doesn't really seem to be a major impact on stroke. So greater intensity of glycemic control doesn't really seem to have a major impact on rates of stroke, although there's a fair amount of variability amongst the trials. And then most alarming, particularly to those of us who participated in the ACCORD trial, what were the results related to mortality. So if you look overall at the data across all of these trials, more intensive glycemic control doesn't appear to have a major impact on mortality rates. However, in the ACCORD trial, which you can see, the data of which is presented here, that glycemic portion of that study was in fact halted early because the individuals assigned to more intensive glycemic control, that is an A1C target of less than 6%, were in fact more likely to die than those who had a more relaxed A1C target of between 7 and 7.9%. Now, some have argued that the UKPDS was the only trial that demonstrated that more intensive glycemic control can convey a mortality and cardiovascular benefit with confidence because it went on much longer than the other trials. But again, it is very difficult to discount any intervention which appears to increase rates of mortality. And I have this slide on the screen because what's happened as a result of the findings of those trials is that there's been a very significant emphasis in the diabetes world to take a multifactorial approach to cardiovascular risk reduction and to rely less upon glycemic control as a determinant of long-term health, but really to focus on blood pressure and management of dyslipidemia as sort of equal partners in reducing cardiovascular risk. The A1C goal still remains, at least these per ADA guidelines, less than 7%, but there are now caveats that if there are individuals who are older, have more established complications, who simply are really hard to get down to less than 7% without an excess of medications, that goal can be relaxed. The LDL cholesterol goal, at least as of early this year, still remains a threshold, but it is a statin-based approach. And my guess is it will change to mirror more closely the ACC-AHA guidelines in the next go-round. So, but we have to be doing something right. This is maybe a difficult slide to see, but this shows the rates of macrovascular complications and end-stage renal disease in those with diabetes over time, so between 1990 and 2010, and then those without, compared to those in the population without diabetes. And of course, rates of all these complications are higher in patients with diabetes compared to those without. But you can see that over time, we've really made some good headway with respect to reducing rates of myocardial infarction and stroke. Rates of amputation have come down a bit. End-stage renal disease staying kind of flat, unfortunately. But we need to be doing something right. And you can see that the rates started to come down, certainly at 2000 compared to the 1995 data points. And I have to say that really the focus was on glycemic control between those two periods of time. So it's likely that better control of glycemia has some impact, but certainly isn't the whole story. And of course, even if the rates of complications are reducing, there's so many people affected that the sheer numbers of myocardial infarctions, et cetera, that occur in this population remain very dramatic. So just a recap, and this is familiar to endocrinologists, but perhaps not to everyone in the room, is that the glucose-lowering therapies are indicated really solely to improve glycemic control, and they're really not expected to demonstrate that they reduce rates of complications at all. There is an assumption when you're giving someone a medicine that reduces the A1C that as a result of that A1C lowering, complication rates will also be reduced, but that's not entirely clear that it's the case. But in any event, there are enormous numbers of medications really geared towards glucose lowering or addressing rates of diabetes complications in development. So we're likely to see more and more classes develop and become available. But I put this slide up because I actually think this is kind of a funny algorithm, and I don't know how to get on in this guideline writing racket, but essentially after metformin, we don't really know what to give to people. And this is just kind of a listing. I mean, it is, let's be honest. And there just isn't much to guide the selection of medications after that initial drug. Now, there is a trial in process called GRADE. We're also recruiting for this, looking at individuals with type 2 diabetes on metformin who need to start a second agent, and they get randomized to one of 4 interventions listed here in an attempt to really try to solidify the preferred approach. It's not clear to me that there will be dramatic differences between these various medications beyond what we know here as far as impact on weight, rates of hypoglycemia, et cetera. But it certainly would be nice to know if there's a particular standout among any of these drug classes that we should use preferentially, because right now we really don't know. And this I've mentioned. Some of the newer agents, interestingly, so the DPP-4 inhibitors in particular, and the GLP-1 receptor agonists, because of their the information from preclinical studies, lots of animal studies, and also, particularly with respect to the GLP-1 receptor agonist, the effect of that class of drug on body weight. These drugs are theorized to potentially reduce risks of cardiovascular complications and could be preferred classes. However, interestingly, the first 2 cardiovascular outcomes trials of DPP-4 inhibitors examined did not show a significant reduction in rates of major adverse cardiovascular events. And in fact, there was a suggestion that the use of these agents increased rates of hospitalization for heart failure compared to placebo that we need to explore further. The TCOS results, the sitagliptin outcomes trial, those will be available later this year. And then again, the GLP-1 receptor agonist and SGLT2 trials are still pending. So why is diabetes so difficult to manage? The main problem is, again, for non-endocrinologists here, that when you're diagnosed with type 2 diabetes, you probably only have about 50% of beta cell function. So you've only got about 50% of your insulin secretory capacity left. Now, often that's enough for you to be able to control your blood sugars adequately with one medicine. But over time, the natural history is such that the beta cell function tends to steadily decline over time, and then the intensity of therapy needs to increase correspondingly. And many people, if not most people, will eventually require insulin to adequately control their diabetes. And what we'll probably see in the future with respect to interventions geared specifically toward this are interventions or medications or other things that might alleviate the amyloid deposition in the pancreas, which appears to contribute pretty dramatically to the loss of beta cell function over time. There's a lot of interest in exploring further the use of early aggressive blood glucose lowering early on in the disease course, either, again, very soon after diagnosis or perhaps even prior to that. There are many people who feel that preferential use of the incretin-based therapy, so again, the DPP-4 inhibitors, GLP-1 receptor agonists, might slow or ameliorate this decline in beta cell function over time, certainly not yet proven. And then there's a lot of interest, particularly from animal studies, as to whether or not an alteration in the gut microbiome might be of benefit as well. So the question is, are we really doing the kinds of studies that are going to answer these questions? And this is information from a publication last year, which I worked on with several other members of my division, Wanda Lakey, Karen Bernard, Brian Batch, as well as some of the statisticians from the DCRI group, Karen Chiswell and Asma Tasneem, looking at data from the clinicaltrials.gov data set, which was downloaded in late 2010. And essentially a database containing this information was made available. And what we did was, and then the group of trials that we focused on were those that had been registered between 2007, when the FDA required entering of really more extensive clinical trials information, again through late 2010, and then we spent quite a bit of time identifying mesh and non-mesh terms to pull out those trials which had, or as their primary focus, diabetes care or management of diabetes-related complications. And we looked at, again, these were, the interventional trials. And when we pooled all this information and really looked at the type of trials that were happening, or at least that had been registered in clinicaltrials.gov, which does represent, I think, at least 80% of trials happening worldwide on the whole, what we found was that the majority of trials really were focused on treatment of type 2 diabetes, and a much smaller number included interventions intended to prevent diabetes, and very few related to diagnostic or screening-related interventions. And the interventions that were provided within these trials, again, were primarily drug-related. A smaller number related to behavior, some supplements, and really a pretty small number looking at the effects of procedures. So certainly gastric bypass surgeries or other weight loss surgeries would fall in that group. When we looked at the number of participants who were in those trials, which is sort of reflective of the ability to answer questions with confidence, they were fairly small. I mean, the vast majority enrolling fewer than 500 subjects, and again, the majority still with a planned enrollment of fewer than 100 or fewer subjects. And they really didn't go on very long on the whole. So if you look at the mean, and again, when we're talking about duration, this is essentially from the study start date to the date when follow-up for the primary endpoint was complete. And so the duration of time that each individual patient is followed within the study is probably even shorter than listed here, but the mean duration of these trials, 1.8 years, median 1.4. Obviously, some were fairly lengthy. And when we looked at the types of individuals, that the trials planned to enroll, interestingly, almost everybody had to be an adult, which is interesting because even though young people are not disproportionately affected by type 2 diabetes, those rates are clearly going up, and that's really the future. And so certainly not a lot of attention being paid to young people with diabetes. And interestingly, it seems like the medicines that we use to treat adults with type 2 diabetes don't work very well, and certainly don't work very long in this population too. So this is certainly an area that's going to need, certainly a group of people who will need attention in the future. Again, remember, those who are aged greater than or equal to 65 are disproportionately affected by type 2 diabetes. And a lot of these trials excluded people who were over 65, and absolutely the majority excluded those who were aged greater than 75. So you're automatically preventing those types of individuals, so the most at-risk group, and those who are most likely to be using these medications from participation in clinical trials where the effects could be reliably assessed. We looked at number of trial sites, 66% taking place at one site. You're really unlikely to enroll a diverse group of individuals and acquire information translatable to a large number of individuals in a trial that takes place at one site. And then we also looked at the distribution of the studies worldwide. And this is just, I'll show you on the next slide how this matches up to the prevalence of diabetes in these various parts of the world. But you can see, unsurprisingly, and this is not number of sites, so this is number of trials with at least one site in these various countries. And of course, it's a heat map, so those that are of greater intensity of color have the most trials. So North America, Mexico, Western Europe, China, and India participating in at least 100, so between 100 and 250 diabetes-specific trials, but large parts of the world not particularly active at all. And this may be difficult to see, but in particular, there are some interesting discordances here. So when you look, for example, at the Middle East and North Africa, where I believe the prevalence of diabetes is estimated to be above 12% now, not much happening. And obviously there are reasons for this, but these individuals may differ, of course, in their responsiveness to various interventions compared to those in the rest of the world. And it may be worth paying particular attention to where our trials are in fact happening moving forward. We looked at the primary outcomes of these trials, and there was a bit of a focus on things other than glycemic control, but the majority really were focused on glycemic outcomes. There was one trial at the time that was focused on rates of malignancies, and there's a tremendous amount of interest in determining how at-risk individuals with diabetes are for developing malignancy in the first place, and then the impact of various medical therapies on malignancy rates. There was one study going on that had been registered during this time period, and that was the TIDE trial, which was in fact discontinued. There is interest in the impact or the relationship between diabetes and bone disease, rates of fractures, the impact of medical therapies on rates of fractures. There were 7 out of 2,500 primary outcomes identified. And at that time, there were 35 that focused on major adverse cardiovascular events or mortality as an outcome. But these are tiny fractions of the whole. There's a lot of interest, again, in rates of pancreatitis, comparable to what I've mentioned with malignancy. There weren't any that had as their primary outcome pancreatitis. The good news is that these trials, if they enroll enough patients and go on long enough, can collect a lot of sort of ancillary information related to these other problems that can help us to answer many questions in one, or at least provide us with higher quality information than we currently have. So again, most of these trials enrolling few patients, happening at one site, don't go on very long. You're sort of excluding those at the extremes of age, which are really an area of those are groups of particular interest with respect to diabetes management. For the most part, didn't really focus on complications of significant clinical interest, and the distribution of these trials doesn't sufficiently involve affected populations. So getting back to the original question, about the global burden of diabetes and whether or not promising new therapies will be sufficient, I get the best answer I have is maybe. And it's going to be more likely to happen if we can focus on various things moving forward, including identification of high-risk individuals early, but only if we're going to do something about it, because it's probably of limited utility to identify millions and millions of people with prediabetes and just take no action whatsoever, and not to implement strategies that we know to be efficacious. If we can implement practical, effective, and cost-conscious preventive strategies, and that's going to require that trials be performed in parts of the world where, for example, patients are not going to get bariatric surgery. It's not an option. And then with respect to surgery itself, I think we're going to see a very significant emergence of surgical intervention as a real key player in the diabetes world. And we know, at least from the information available at present, it seems to be pretty effective in a preventive sense. Patients with diabetes who undergo bariatric surgery may experience a remission, and interestingly, it looks like it's more effective in resulting in remission if it's done very early on in the disease course. And so, again, just kind of sitting on people and treating them with strategies that aren't particularly effective is probably not a good overall game plan. I think we'll see a lot of interventions or exploration of interventions designed to arrest or reverse beta cell function, which is such a key physiologic problem in type 2 diabetes. We also, again, because we know that early treatment of hyperglycemia, adequate treatment of hyperglycemia soon after diabetes diagnosis reduces rates of microvascular and macrovascular complications. That's the group we really need to focus on kind of before they get too far along the path of poor control. Again, we've got to address multiple cardiovascular risk factors. It's not just all about management of glycemia. Of course, we need to better understand the long-term impact of our therapies and really to answer the questions that we need to for all of the patients that we'll be treating in clinic. We've got to get, I've described them as the right patients in clinical trials, and we got to get some older people in, we need to get some young people in, and we need to get very diverse groups of individuals enrolled in these trials so that when we're faced with a choice of what medication to prescribe to a particular individual, that medication has been studied or that intervention has been studied in at least a handful of people who were relatively similar to them. But I like to close with this slide. Supposing is good, but finding out is better. Interestingly, this probably was written or said by Mark Twain, but it's actually hard to document that. But you can now, I think, or in just a few minutes, text for CME credit, but I'd be happy to take any questions that you have. I know this was a fairly big look at diabetes, and it's a big problem. I'm sure I didn't talk about everything you were expecting to hear. Yes?
So, thank you for this presentation. I work with the clinical patient with diabetes, obesity, and then it was a cardiovascular disease and diabetes study. When we compared the two groups with the bariatric surgery patient and the patient treated with the medication, we were measuring the intima thickness, carotid artery, and also the thickness, and then
Flow-mediated vasodilation or something like that?
Definitely. At the end of the study, the recovery was 98% with the bariatric surgery patients. And then hemoglobin A1C level definitely decreased. Blood pressure definitely decreased. Even we measured we compared with the gene expression, E2, F4, and then lectin, and then they were changed at the end of the study. It's very, very important, and it was really significant. So I think cardiovascular disease and diabetes, it's like a, sister and brother.
Right, and it's actually rather artificial to separate them because There's so much overlap. They're almost part of essentially the same disease process. It's just that we focus on different manifestations of this sort of dysmetabolic milieu. Now, I'm going to say something that's probably going to be sort of unpopular, but I think it's interesting when we look at things like carotid intimal medial thickness, but I don't really care what my patient's CIMT is. What I care about is whether or not they have a stroke. And so even though we have information like that from clinical trials, it's really important that if there is a trial like that happening, or there's an intervention that seems promising based on those sort of surrogate endpoints, that there are trials that go on long enough that we can actually determine whether or not our intervention has reduced rates of stroke. Because the CIMT, I don't really care about very much, and my patient doesn't really care about very much either. So just to encourage, that these trials be big enough and go on long enough that we can answer those questions with confidence. But yes, I think bariatric surgery, what it boils down to is weight loss is very, very good for you if you have diabetes or you're at risk for diabetes, and bariatric surgery is a very effective intervention which results in very significant weight loss for almost everyone who gets it. But again, many of these trials, I'm not sure about your specific study, they're not randomized, and so there may be differences when you look at the group of individuals who are able to undergo bariatric surgery. There may be certain things that characteristics of those patients, their economic circumstances may differ considerably from other heavy people who can't undergo the surgery. So it's difficult to do randomized trials of something like bariatric surgery, but I think we need to think creatively maybe about how to do something like that moving forward. Yes.
There have recently been on WUNC radio some public service announcements about the prevalence of diabetes being much higher in urban areas than in rural areas. And I wonder if there are some studies that are working on environmental factors rather than person-by-person interventions.
I know that I am less familiar with those, but yes, there is a lot of interest in trying to identify factors in the environment that may contribute to the development of diabetes. And some of these are related to things like toxicity, potential toxins in the environment, and some of them simply have to do more with the lifestyle, or it's hard to differentiate economic status too from where you live to a certain degree. So yes, there's quite a lot of interest in that. It's difficult to know how amenable that kind of information will be to meaningful interventions. But yes, absolutely. I mean, it's not. It's a very complex condition, and there may well be things that we're exposing ourselves to in the environment that are contributing to sort of this burgeoning problem that we really have no idea of at the present time.
Thanks for a nice overview on a large problem. I have one question for just keep continuing to opening it up. Multifactorial interventions. You mentioned sort of really a lot of the studies you described focusing on A1C control. Mm-hmm. Studies like STENO2, which were conducted in the 90s, had, in 7 to 8 years, tremendous impact on mortality, cardiovascular events, progression to ESRD. What are your thoughts on that, and how can we also, alongside pharmacologic therapies, also address sort of multiple pharmacologic therapies with lifestyle?
Right, so the Steno group was way ahead of the curve, and I think that group of individuals understood that we needed to look beyond glycemic control to keep our patients healthy over the long term, and those are really seminal studies that showed the effectiveness of this multi-pronged approach, primarily focusing on certainly glycemic control, but also really aggressive management of hypertension and fairly aggressive management primarily with statin therapy of lipids, as was appropriate for the time. And those were incredibly effective interventions. And I think the rest of the world has come around to that. It took us a while. I think there was an interest in trying to reproduce those kinds of results in larger trials. The Steno group's trials weren't necessarily particularly they were small. So there was certainly an interest in translating those results into larger groups of patients. But it's very clear And I see some of my fellows here, but often I'll tell them, anytime you sign out a patient with diabetes to me, I'm going to run their med list, and if the statin's not on there, there needs to be a really, really good reason why. Because there's essentially almost no reason for a patient with type 2 diabetes not to be on a statin at this point. With respect to lifestyle modification, that's really kind of the wild card. And it's easy to write a prescription for an antihypertensive and have it work as long as the person takes it, but lifestyle is very, very complex. And there are some potentially successful ways to translate, for example, the lifestyle intervention in the diabetes prevention program into the community. And I think that the YMCA seems to be a kind of a good practical avenue for individuals to receive lifestyle counseling and then have it consistently reinforced over time. And we'll see whether or not the engagement of the YMCA in those kinds of activities will have a meaningful impact on the population served. But lifestyle is very difficult. I wish I had the answer to that. I think there's, Americans, we don't like to deprive ourselves of anything. We don't like to have to say no. We don't have to, not have that piece of cake. And but I think moderation. I'm not a proponent of extreme lifestyle change or extreme diets, but just this continued emphasis on moderation and thoughtfulness with respect to lifestyle can go a long way, and just modest changes can be very effective, but easier said than done.
Great, thank you.
Yes?
Do you have any public policy recommendations, specifically like around weight loss or any other risk factors that could reduce not only the prevalence, because when you said 1 in 3, looking forward, that sounds like a public health crisis to me.
Well, it's definitely a public health crisis, and I'm going to generalize here, but in a person who's at risk for diabetes, so someone with prediabetes, for example, reducing their body weight by 10% appears to be a very meaningful preventative intervention. And so at-risk individuals don't have to lose down to a normal weight per se, but even a modest weight loss appears to really change the trajectory, but it needs to be sustained. And that's what is often most difficult. I think there are a variety of different recommendations out there for exercise. Remember that exercise is really, really good at helping people keep weight off once they've lost it. It's really difficult to lose weight through exercise because a pound is, I think, about 3,000 calories. It's hard to burn that many calories in excess of what you're eating through exercise alone. So the emphasis really has to be on a reduction in calorie intake to accomplish the weight loss, but then physical activity is certainly a key component in maintaining the lifestyle change over time.
Another question? Great. I want to thank you for a great overview of a very large problem. This is a great way to close out November to raise our awareness of diabetes. We're going to kick off next. Sorry. We're going to kick off next week's conference on Monday. It's a special session with Dr. John Bartlett to help us celebrate World AIDS Day. And he's got a special presentation for us. So it's on Monday, not Tuesday, same time, same location. Thank you.
Yeah, thank you very much.